Hello everyone. Today, let's talk about embolism. First, we need to know what is embolism. By definition, embolus refers to the detached, intravascular, solid, liquid, or gaseous mass that is carried by the blood to a site distant from its site of origin. Actually, nearly 99% of all emboli represent some part of a dislodged thrombus, which is designated thromboembolism. Other forms of emboli include fat droplet, gas bubbles, tumor fragments, foreign bodies, and so on. Unless otherwise specified, an embolism should be considered to be thrombotic in origin. Principal outcome of embolism is the ischemia of downstream tissues, so-called infarction. Embolism may take place anywhere in the vascular tree, either in the pulmonary circulation or the systemic circulation. Generally speaking, emboli originating from the systemic vein or right heart tend to cause pulmonary embolism, whereas emboli originating from left heart or systemic arteries mainly lead to distal systemic arterial embolism. In pulmonary embolism, more than 95% of all cases are caused by deep leg vein thrombi above the level of the knee. After detachment from the sites of origin, the thrombi are carried to the right heart by blood flow and further enter the pulmonary circulation. Depending on their size, the emboli may occlude the main pulmonary artery or pass out into the smaller, branching arterioles. The clinical significance of pulmonary embolism depends on the extent of embolism, the number of emboli, and also the circulatory state of patients. In most cases, 60 to 80%, pulmonary embolism is clinically silent since the size of emboli is small. But in some other cases, when more than 60% of pulmonary circulation is obstructed, right heart failure or even sudden death may take place, like in the case of a large embolus obstructing the bifurcation, saddle embolus. Emboli in the arterial circulation mainly source from the intracardiac mural thrombi, in which 2/3 are associated with left ventricular wall infarction, and 1/4 are associated with dilated left atria. Arterial emboli can travel to a wide variety of sites with blood flow and lead to embolism at the sites of arrest. 70 to 75% of all arteriolar embolism takes place in the lower extremities and further cause gangrene in the legs, whereas another 10% occurs in the brain. The other vulnerable sites include intestine, kidneys, spleen, and upper limbs. The consequence of systemic embolism depends on the caliber of the affected vessels, the vulnerability of affected tissues to ischemia, and also whether there is collateral blood supplement. In general, arterial embolization causes infarction of the affected tissues. As we have already mentioned, besides dislodged thrombi, other substances can also work as emboli, such as fat droplets, gas bubbles, and so on. Considering fat embolism, fat droplets usually enter the circulation after severe skeletal injuries or significant trauma of soft tissue. The pathogenesis of fat embolism involves not only mechanical obstruction, but also biochemical injuries, especially the endothelial injuries caused by free fatty acid released from the fat globules. Typical clinical manifestations of fat embolism include pulmonary insufficiency, neurologic symptoms, anemia, and thrombocytopenia, and it is fatal. in about 1/10 of all cases. Here, this picture shows subcutaneous hemorrhage caused by thrombocytopenia. Fat embolism can be demonstrated microscopically by fat staining with frozen sections, where either oil red O stain or student red stain. Fat droplets are red stains as shown in this picture. Air or other gas belongs to another category of emboli, which cause obstruction of vascular flow, as well as the thrombotic masses. Bubbles of air may enter blood circulation during obstetric procedure or as a consequence of chest wall injury. Only when the volume of air entering the circulation exceeds 100 milliliter will there be obvious clinical manifestations. A particular form of gas embolism is decompression sickness, or the so-called caisson disease. This kind of embolism mainly affects the deep-sea diver and underwater construction workers. When the divers ascend to the sea level too rapidly, the nitrogen formerly dissolved in their blood and tissue is released out and forms gas emboli, which further leads to ischemia in numerous tissues. Another particular type of embolism is amniotic fluid embolism, which is a rare obstetric complication. In the process of labor, tear in placental membrane or rupture of uterine or cervical veins, amniotic fluid or fetal tissues into maternal circulation. Though the incidence of amniotic fluid embolism is relatively low, this rare complication is one of the major causes of maternal mortality. The clinical manifestations include sudden occurrence of severe dyspnea, cyanosis, hypertensive shock, and the following seizure and coma. Even the patient survives in the initial crisis. She may further undergo the later pulmonary edema, as well as disseminated intravascular coagulation, DIC, which are caused by the release of thrombogenic substance from the amniotic fluid. Typically, the histologic changes of the patient's lung tissue include pulmonary edema and diffuse alveolar damage. And in the pulmonary microcirculation, presence of substance from the fetus may strongly support the diagnosis of amniotic fluid embolism, including squamous epithelium of fetal skin, lanugal hair, and fat or mucin from the fetus. Thank you, everyone. The class is over here.